Well, that's the topic of the talk. Most of the data that I will be presenting has come courtesy of VASM, and in particular, comments made by first-line and second-line assessors. The cause of death in the period 2012 to 2016 is stated there. There's nothing new there. Most of those causes of death are unavoidable and inevitable, but there are things that we can do. All of those causes of death are based on clinical grounds. They're clinical diagnoses. And I think that one of the sad things that has happened in my time is that the post-mortem is virtually disappearing. And I don't think that's a very good thing. Certainly when I was a medical student, every patient who died in a public hospital had a post-mortem. There was an opt-out clause if you could find it in the hospital. At the Royal Melbourne Hospital, it was on the inside of a broom cupboard door in the basement. So virtually all the patients who died received a post-mortem, and it was a very good learning experience. It's still important in forensic areas, so why isn't it important to us? Because we still get surprises. Most of the post-mortems that are done these days, which are very few, are ordered by the coroner. Very few are done in the hospital. 3% refused, 50% didn't get a post-mortem, and in 22% it was not known whether they did or not. I would advocate the use of the post-mortem. It's important and becoming more difficult these days to establish, as far as patient care is concerned, who is responsible for the patient. And in this era of increasing specialisation and increasing use of intensive care, it is often difficult to find out who is in fact driving the bus. And it is important that seniority takes a part in this, and particularly in decision making. Very often, particularly in emergency patients, at night, decisions are taken by very junior people without consultation. And this is a fact of life, and I would advocate escalating problems where the decision is out of the scope of the person faced with it, and escalating the decision-making process up the line to the senior people. Also, who is doing the operation? This is important, and often is not even acknowledged. Communication, the single most important element in patient care. It's important that everyone involved in patient care, nursing staff, junior medical staff, senior medical staff, are aware of what the plan is, are aware of what is happening, aware of what the diagnosis is, and it is, again, most important that everyone is aware of what's going on. It's important, and a lot of work has been done recently on the benefit of formal handover. This usually happens in the morning after a night's receiving, and it also goes at all levels. So if the consultant surgeon is going away for a few days, it's important that there is a face-to-face handover with the person who is taking over the management of the patient while he's away. And one of the great series of problems that does occur, and if you look at cases that come up before the coroner, or if you look up cases that come up before various regulatory bodies, this is a very common situation. where the person who was nominally in charge of the patient didn't know about it. I might also say it's very important to let the switchboard know if there has been a change, because again, they become important in this instance. Patient transfer, 20% of patients need to be transferred, and these are all, I might say, these are all VASM cases. They're all ultimately deaths. But 20% of patients who do come to VASM have been involved in an inter-hospital transfer. And there are problems with this, and these problems are reported by the surgeon in charge and also by the assessors, first line and second line assessors. And issues such as delay is obviously important, and this occurs in almost 10%. The inappropriateness of staff involved in the transfer is an element in 6%. And insufficient clinical information going with the patient still occurs in almost 10%. And this is clearly ridiculous. It's clearly very important. Again, these patients are all patients of VASM. So 69% of patients receive critical care support. That's not surprising. The treating surgeon regarded the lack of critical care as it being an issue in 2.3% of cases, and the assessors increased that to 9%. The management of the frail patient is becoming increasingly significant, and I think that one of the best examples of clever management has come in the management of patients with fractured necks of femur, where the patient is basically managed by a geriatrician and the surgeon is called in to do the operation. They are basically old, sick people with a surgical problem, but the major problem is the fact that they are old and sick. And perhaps this model can be extended. Futile operations, this has been something that's concerned the college. It is often easier simply to go along with the patient and the family's feelings and operate in situations where it is, frankly, if you stand back and have a look, ridiculous. And as I said, it is occurring more frequently, and it's being considered by the college along with end-of-life matters. Post-operative complications, this is one of the major issues at mortality, morbidity meetings. It comes up week after week. The patient with leaking anastomosis is diagnosed as having pneumonia. A patient who has a post-operative bleed is diagnosed as having a cardiac problem because of the hypotension and the tachycardia. So early senior involvement is most important in the diagnosis and management of post-operative complications. The issue of the deteriorating patient post-operatively is extraordinarily important, and recognition of the deterioration and then doing something about it and doing something about it promptly are vital. 34% of VASM's patients experience post-operative complications, especially bleeding, anastomotic leaks, graft occlusions, etc. Unplanned return to theatre. This has a dire prognostic, is a dire prognostic element, and approximately 16% of the patients return to theatre unplanned. I'm not talking about those patients who have a planned review. and this is unchanged over at least the last 10 years. Deep venous thrombosis prophylaxis is important. The common modalities, heparin and compression devices. 17.5% of patients had an operative procedure who did not receive DVT prophylaxis because of various medical and other problems. An omission error rate of 4.2% is really not acceptable. Fluid balance problems thought to be an issue by the assessors in 8% of cases. Infection control, 58% of the patients developed infection during admission. Most of these were in fact pneumonia, but also wound infections. Infection control is important. It's incredible how effective hand washing is and how it was only discovered recently. But it must be enforced. And antibiotic use is used in a fairly ad hoc manner, both prophylactically and therapeutically. And the advice is that the Australian guidelines for prevention and control of infection in healthcare should be better utilised. It's readily available. Thank you.
Bang on time. Thank you very much.